TopMedTalk.
Monty Mython here. As we prepare to move into the next phase of the COVID crisis, we're going to be widening our focus here on TopMedTalk. We will continue to deliver COVID-specific programs, but we all have a huge additional responsibility as we try to reboot normal services. So although this piece is not directly related to COVID-19, we believe it's information that is crucial to the bigger task of rebuilding the healthcare system as we learn to adapt and live with this new virus. Thank you to our sponsors and to you, our listeners, for helping us to share this important information.
I'm Monty Mython, Anaesthesia Critical Care, University College London, and Chairman of the Board of Evidence-Based Perioperative Medicine. I've been asked to step in at relatively short notice to chair this session because I think they were looking for a completely impartial chair and they couldn't find one. So this is going to be discussing troponin screening. Now, troponin's attracted a lot of attention, particularly in the context of something called MINS, myocardial injury after non-cardiac surgery. So we're going to be discussing troponin screening, essential or emperor's new clothes. And we're going to hear from Duminda Wijeysundera. Duminda, thank you.
Thank you very much, Monty, for the introduction. So, as you can tell, the title of this presentation is Troponin Screening, Essential or the Emperor's New Clothes. This was not my title. I think it came from the organizers. So you might get a sense that there's a pre-existing bias towards the value of troponin screening. And I suspect I'm going to speak a little bit in favor of it or explain why it's useful. And I suspect I'm on the harder side of the argument. But I'll do my best. So what I hope to convince you is that this is actually not the emperor's new clothes. It's not something without value. It is a very useful, but I would argue somewhat misunderstood clinical tool. And I'll sort of get at that. I just want to acknowledge my sources of funding support. And I've got no relevant conflicts of interest pertinent to this presentation. And what I thought I'd start off with is maybe a discussion about the common perceptions of troponin screening, the reasons why people often think this is a waste of time. And these are things that I admit I've said myself, I've definitely heard from my colleagues, and it makes it very hard to understand what the role of troponin screening might be. So I think a lot of people say that all it detects is asymptomatic troponitis, and frankly, most of these elevated troponins mean nothing. And on top of that, and I've seen this a lot myself, when you refer your patients with elevated troponins to cardiologists or internal medicine physicians at your hospital, frankly, they don't really care about it much either. And there's no real treatment. And God forbid, based on the results of the MANAGE trial, which is a RCT of dabigatran for patients with myocardial injury, you might be afraid that somebody's going to start these patients on dabigatran. So this is kind of the feeling you often get when you think about troponin screening. And I think part of the reason, frankly, is that there are actually good data showing some value from troponin screening, but there are some areas of uncertainty in the evidence. But people have oversold it. So I think this is a real example where if you oversell something and tell somebody that a test is more useful than it is, or it can do a lot more things than it is, it actually results in cynicism and pushback and perhaps a discounting of its true value. So let's maybe take a step back and I'll discuss some of the reasons why it's useful. So let's just think about what a test might be useful for in terms of clinical care. So I think if you had a test that could diagnose or screen patients for various conditions, I think most of us would agree you'd want something that could detect otherwise missed acute conditions, something that could help you target therapy to treat those conditions, perhaps accurately stratify risk for important outcomes. You know, that's a reason we do use clinical risk indices, why we do CPET before surgery is frankly to risk stratify, among other things. And finally, it would be nice to be able to diagnose chronic conditions that require long-term management, especially when we think about a move towards integrating perioperative care with long-term care, if this is really a model for where perioperative medicine should go. Like when we talk about getting people started on exercise because it's good for them, well, we think about exercise over the long term. Perhaps there's something similar with troponin screening. So let's address each of those points. So the first thing I want to talk about was detection and treatment of post-op myocardial infarction. So I'm not talking about MINS or troponitis or myocardial injury. This is just infarction, good old infarction that we all know. There's reliable criteria for this. We all would hope that these are events that we would hope to predict and prevent. So how often does infarction actually occur? So it's not exceptionally common. It doesn't occur in a third of our patients, but it's not exceptionally rare either. So these are some data showing how often it occurs in contemporary patient populations. So the first two are the vision studies from P.J. Devereaux's group, unselected patients aged greater than 45 years of age undergoing major non-cardiac surgery. In the first vision study, it was about 3 and 3.3% of patients had an MI. It was about 4% in the second vision study. And these are unselected patients. So let's say you just focus on patients who at least have some risk factors for coronary artery disease. That's kind of this group that participated in what was called the CTA vision study. That event rate was 7%. But if you applied even simple risk stratification criteria to screen patients to decide who needs troponin testing postoperatively, chances are you're going to identify a group of patients where that event rate is 8% to 14% in screen populations. The important thing is you will detect that rate only if you test patients. And the reason for that is troponin screening is integral to the diagnosis of infarction in any setting. So, we've had ever-improving troponin assays, and what you see here are sort of the improvements in troponin sensitivity over the years with different assays. In the non-operative setting, we've got fourth and fifth generation troponins that allow us to detect myocardial infarction way closer after somebody's had chest pain. The difficulty in the perioperative setting is in studies that have looked at this, only about 50 to 70% of patients have essentially no symptoms, although they meet other criteria for infarction. So we don't know all the reasons why that is the case, but essentially if you don't test these patients with troponins, you will not detect them. So what kind of burden of misdiagnoses are we talking about? So let's say we assume about 70% of patients would have their diagnosis missed if you didn't test them. Well, if you took unselected patients, that would mean about 3% of patients would have a myocardial infarction that went undiagnosed postoperatively. If you picked a higher risk population where you screen them, it's about 5.5% to 10% of patients. So what's the potential gain from actually screening such patients? So sort of the number needed to screen, if you looked at that. How many patients would you have to screen with troponins to actually detect an infarct that you would have missed otherwise? It's only about 35. That's actually pretty good for most screening tests that you'd actually employ. That's in unselected patients. If you looked at more screened, selected patients, it's about 10 to 20 people. So this is a pretty reasonable test to pick up a condition for which we have treatment. And importantly, we have treatments. So in terms of treatments, we can differentiate, and I think it's important to differentiate between short-term treatment and long-term treatment. In the post-op setting, most of these infarcts are what are called type 2 myocardial infarctions, so largely driven by supply-demand imbalance. So when you diagnose them, then basically you focus on the things we normally would do as anesthesiologists, essentially optimize a balance of supply versus demand in these patients. Now, people would argue we do this anyway, but I would tell you that if we look at the data, especially outside the operating room, which is when these infarcts generally occur, and the rates of hypotension, hypoxemia, and poor heart rate control that occur on the wards, that rate is exceptionally high. And it would tell us that if we don't detect these patients, most of these patients would go on to have some form of poor hemodynamic control postoperatively, which we would not treat, and allow an infarct to progress to a more severe state where we could have actually controlled it before. I think more importantly, and this is sort of where the future of perioperative medicine is, there's really an opportunity to take a patient beyond acute treatment, but to start therapies that would improve their long-term health. So when we think about our role in terms of improving their overall health, we had to think also of the potential for secondary prevention in these patients. So what does secondary prevention mean? It means actually therapy aimed at preventing recurrent events in patients who've had an infarct. We're not talking about treating the initial event. It's about treating future events. And this is important for a couple of reasons. The first is that what you're trying to do is reduce complications of a myocardial injury, so basically prevent progression to heart failure and prevent recurrent vascular events, so progression of vascular disease. And again, if we think about the idea of linking perioperative care to long-term management, we need to do this. And the only way we can do this is actually identify people who've had the disease or the event occur. Now, what are the types of things you can actually offer patients? This is actually a very nice review on secondary prevention strategies published in the Canadian Journal of Cardiology. It's not just because it's a Canadian journal, it's actually a pretty good article. But these are all things that you can do for patients who've had an infarct to improve their long-term survival. And importantly, when people have actually studied medical therapy of patients who've had an infarct postoperatively, the vast majority of them do not receive most of these things. So there's a huge scope for improvement. Now, I talked briefly about dabigatran and how crazy an idea is, but I thought an interesting point to raise here is actually, if you look at disease modification for patients who've had an infarct in terms of secondary prevention, dabigatran actually is not as crazy an idea as you think it is. I wouldn't necessarily start in my patients, but I'll explain why the results might make sense. And I'll just give an example of a trial outside anesthesia. So this is the COMPASS trial. It was a large randomized controlled trial of almost 28,000 patients who had established vascular disease. And they were randomized to a strategy of aspirin in combination with low-dose rivaroxaban at 2 doses. And the primary aim was to see if this addition of a novel oral anticoagulant would prevent important cardiac events, so cardiac death, stroke, or myocardial infarction. And over a 3-year follow-up period, what they found was that addition of rivaroxaban at a low dose was highly effective in preventing those events from occurring. So novel oral anticoagulants prevent recurrent events in patients with established vascular disease. So dabigatran is a novel oral anticoagulant. So if you look at it from that framework, then actually the managed trial might actually make sense. So the first thing is the types of patients who were recruited in the managed trial, so basically people who had postoperative myocardial injury. If you looked at their event rates for death, cardiac death or myocardial infarction over long term, they were actually way higher than the COMPASS trial. So these are really high-risk patients. On top of that, dabigatran was not given as a short-term treatment. That's actually often, I think, where the misconception of how the drug was used. I'm not saying the people who conducted the trial sort of pitch it somewhat differently sometimes. But if you look at the time from when people were diagnosed with myocardial injury to when they got dabigatran, the median time from MINS to randomization, so the earliest point at which they could have actually got dabigatran was 5 days. So this is not acute treatment. This is not half an hour, 24 hours after injury. It's a long-term therapy. So in that context, again, something like this would actually work in patients because dabigatran probably is not an acute treatment. It's something for long-term therapy. But again, any benefit you could get with a drug like this requires you pick up the condition. Now, I'm going to talk about the easiest thing, which is infarction. But I think in that, I think a couple of things are clear. If you don't test for this, you're going to simply miss the diagnosis. And the number of diagnoses we're talking about 50 to 70% of myocardial infarctions. And if you miss them, you miss opportunities to improve their long-term health as well as short-term health because we have evidence-based therapies that we know work in these patients. That's the easy part. Well, what about injury? And I think this is probably the most contentious issue and one where actually the most debate lies. And I think there are at least 2 potential benefits from this. So the first is the idea of risk stratification. So we spend a lot of time stratifying patients' risks before surgery with clinical risk tools, exercise testing, blood tests, a bunch of things. But one of the key things we need to understand is, well, you can take a patient, they have an operation, their risk clearly changes. And it would be useful to understand which kinds of patients at the end of the operation or within the first 24 hours after operation are the ones in whom trouble is actually going to occur. And in that role, the role of postoperative troponins for risk stratification alone is very, very clear. This has been shown in multiple large studies with thousands of patients. The higher troponin elevation after surgery, the higher risk for mortality. Now, I'm not saying that troponin elevation is the cause of death, but it does tell you that that is a patient you need to worry about. And what it tells us is we can focus our attention on a much smaller group of patients. So the figure on the right is a figure from the first Vision 1 study, which looked at, again, about 15,000 patients and used a troponin T assay. And if you look at what's been called MINS, it's a troponin T above 0.03 nanograms per ml. So if you look at that group of patients, those patients probably basically account for about 8 to 18% of patients who are the ones who have myocardial injury, but they account for 45 to 60% of all deaths. So a lot of bad things happen in a small group of patients. So one of the challenges we have postoperatively is who do we need to monitor, who do we need to actually focus our attention on in preventing progression of complications. This is a straightforward way of figuring out, in large part, where the burden of bad events occur. The troponin is not necessarily the causal factor, it's an alarm signal for us to focus on. The other approach that it may be helpful in is actually identifying unrecognized chronic disease. So this is a really interesting study from the anesthesiology group at Utrecht in the Netherlands. Wilton van Klee is one of the investigators there. And what they did was take a bunch of people who had myocardial injury and got them to have CT coronary angiography. So a couple of things. This was about 900 patients they screened. Of those patients, a third of them had established heart disease. So it kind of makes sense. If you have established heart disease, you're going to have myocardial injury. But if you look at the remaining 70%, now they were able to only get about 50 patients to participate in the study because it's a technically difficult study to conduct, as you can imagine. But of the patients who had myocardial injury but who did not have known heart disease, 50% of them, if you actually did CT angiography, had significant coronary disease. So these are people for whom they had no known diagnosis of coronary disease. They had this event occur, and through screening, you can actually identify a disease condition for which we have proven therapies. So is postoperative troponin useful? Well, let's go back to the initial points. Does it detect otherwise missed acute conditions? I would say the answer is yes. I think I've hopefully shown you that's the case. And through that, we can better target the use of life-saving and life-extending therapies. It does accurately risk stratify patients for important outcomes, and in some cases, it may actually help diagnose chronic diseases that need treatment. Now, why aren't we achieving all of those things? Well, I think finally, this is where I think I have to acknowledge the weaknesses in the troponin data. If we are to finally do this or use these data well, or troponin testing results well, we need to look beyond the hospitalization and the inpatient stay. We need to be able to link better what we do as perioperative physicians with what goes on in outpatient care, because we can't manage all of this workup while patients are inpatients. We need to actually move outside the operating room, link with outpatient care, and actually extend the scope of perioperative medicine so we can use these results to improve their long-term care. So is troponin testing useful? I'd say yes, but provided it's used appropriately. Thank you.
TopMedTalk. Nick Wijeysundera here. Have you got yourself onto EBPOM.org yet? If not, you might not be aware EBPOM Chicago tickets are free for a limited period only. Go now to EBPOM.org. Evidence-based perioperative medicine. EBPOM.org.